Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. It's Friday, February 23rd. This week, do we need a national unique patient identifier, AI, in the clinical setting, and how to get started with artificial intelligence project at your health system? This podcast is brought to you by Health Lyrics, a leader in digital transformation in healthcare. This is episode number 7. My name is Bill Russell, recovering healthcare CIO, writer, and consultant with the previously mentioned Health Lyrics. Today, I'm joined by a great friend of mine and a wicked smart data scientist, Charles Boicey. Wicked smart, that's for my friends on the in the Boston area. Charles is Chief Innovation Officer for Clearsense, a healthcare analytics organization specializing in bringing big data technologies to healthcare. Prior to Clearsense, Charles was the enterprise analytics architect for Stony Brook Medicine. In his role, he developed the analytics infrastructure to serve the clinical and operational and quality and research needs of the organization. He was a founding member of the team that developed the Health and Human Services award-winning application Now Trending to assist in early detection of disease outbreaks utilizing social media feeds. Charles holds an MS in technology management from Stevens Institute of Technology and is the president of the American Nursing Informatics Association. Good morning, Charles, and welcome to the show.
Good morning, Bill. Good to be with you.
Wow, you have so many bios out on the web. I hope that one was current. You do a lot of speaking and a lot of different things. Is that one pretty current?
Yeah, it's pretty current with the exception. I'm now past president of the American Nursing Informatics Association.
Past president. All right.
So, yeah.
We'll update.
And I've got one to add for you. I'm a professor at Stony Brook Medicine. I helped them develop out their applied analytics master's program. So I developed 3 classes and I teach 3 classes there.
Wow. So can we start calling you professor?
Yeah, but you'd have to use it at like an assistant level professor, not quite the full-fledged. So,
assistant professor. Now we've worked together for a while. In fact, we were at competing health organizations, and I was so impressed with your work. I brought you in to talk to our team and then eventually to the leadership about what could be done with big data and big data analytics. And I've tried to hire you on several occasions. You're the hardest person to hire. You're so loyal to the people you're with. So I've been stilted a couple times, but I still enjoy our friendship because you really caused me to think about these topics of machine learning, AI, and big data. So one of the things we do is we like to ask our hosts to give us an idea of what they're currently working on or what they're excited about. So what do you have going on these days?
Sure. So there's a couple of things. I'll kind of start out from the academic perspective or education. It applies, yes, in the academic environment, but a lot of the work that I do with Clearsense is actually education. If you think about where healthcare is, as far as analytics, machine learning, AI, and whatnot, many of us are still in the spreadsheet stage, right? Some of us have progressed to data marts and so forth with some visualization, but very few have made the leap into these big data technologies, advanced analytics, AI, and so forth. So a lot of what I do and what I really am excited about doing, is educating clients, prospective clients, and then, as you know, for the last 8 years or so, I've been evangelizing, this throughout the community and whatnot. Yeah, on the professional side, some of the things that we're doing with our clients that I'm really, really excited about are in areas of operations as well as in clinical practice. On the operations side, and we'll take a look at, like, let's say patient access, if you will. We all have a problem with, keeping, the clinics, full and at capacity and whatnot. So a lot of the work that we've done lately is developing out models that, take into consideration patients' future or past attendance habits. We take a look at the weather. We take a look at traffic patterns. We take a look at a lot of different extraneous factors, put that all into, a model, and then give our clients the ability, at the end of the day, these are the folks that are likely not to show up tomorrow. But not just that, give them a list of those that are likely to be able to fill in those slots if those folks, indeed don't show. And so they're able to make those phone calls at night to, get a definitive yes or no, I'm going to be there. If it's a no, we slot somebody else in, and we keep our clinics full. So that's pretty exciting on the operational side. On the clinical side, again, just working on the situational awareness type applications. Loading up the machine learning environment with all the physiology, all of the laboratory data, physiology data, and really identifying patients that are likely to crash in the next 30 to 60 minutes. So again, when we get into the AI side of things today, we'll talk about AI versus what I like to call intelligent assist. So those are the kinds of some of the things that that we're working on that are pretty exciting. It has to be practical, and we'll get into that in a little bit too.
Yeah, so we're still scratching the surface. I remember one of the first use cases you gave me was as a CIO, I was sort of struggling with EMR implementation, and our doctors were struggling to figure out how to utilize the EMR effectively. And you told me about how you use data science to collect all this big data to collect all this information, then use machine learning and data science to determine which doctors were actually having difficulties utilizing the EMR. You were actually able to identify them by name so that you could really do targeted education and training of those doctors based on how they were getting lost in the system, how many clicks, because we have all that data, right? Every click that happens in the EMR, we're tracking it. And you just said, there's value in this data. We'll figure out how to use it. And I thought that was an interesting use case. You still using that? Yeah. Still using that use case?
Yeah, that's the HIPAA lock and so forth. And an interesting side note on that was, and we did exactly what you described. But when you tap somebody on the shoulder because you know where they are at any particular time, and then say, hey, we noticed in the last couple hours you were doing these kinds of things, and it looked like you were struggling a little bit, and that kind of flips them out initially, but after they calm down. You can have that intervention and really kind of help them on their way, and then track them going forward. We had somebody, we had a clinician that was actually getting 150 notices, alarms a day, and which is quite extraordinary. And then once sitting down with them, we kind of helped them walk it through, and they got much less alerts and so forth. So yeah, there's those HIPAA logs. There's tons of data in there. Yeah,
so there absolutely is a cultural aspect of this, and we'll get to that in the second segment when we get there. Let's get to the news. You and I can have really long conversations, so I'm going to try to keep this to a half hour. I doubt I'll do that, but let's see what we can do. So we'll take a look at the news. Here's what we do. Charles and I have each selected a story to discuss, and I'm going to kick us off. The story I picked is from the New England Journal of Medicine Catalyst. Has the time come for a unique patient identifier for the U.S.? So it's a 30-minute show, so I'm going to not share all the credentials, but a couple of names of note who are the authors of this. Harpreet Sood, David Bates, John Halamka, CIO Beth Israel Deaconess, David Bates, CIO Brigham Women's Hospital, and Aziz Sheikh, who's a professor in the University of Edinburgh. Here's a little synopsis of this story. It's time to revisit Congress's fears about the unique patient identifiers and institute a system that will enable more complete and accurate patient records. So a unique patient identifier was proposed as part of HIPAA, but was shot down for privacy concerns. The primary reason for their argument is that a national unique identifier leads to better care. So here's another quote. When accurate information is attached to the right patient, data access is timelier, inappropriate care reduced, and health information exchange becomes easier within organizations as well as between. So, and they also go on to talk about how some states have already implemented this, the state of Nevada and Minnesota. And they say, we can see how those go and scale them up. They close with this. So with billions of dollars having been spent on EHR implementations, the healthcare system must vigorously investigate more efficient ways to connect fragmented patient data, an effort that is increasingly relevant as the U.S. moves from fee-for-service to value-based care. So, Charles, I'm going to go on a little bit of a rant here because I think they accurately capture the perspective of a physician, but I'm not sure that's the right lens to be looking at this. So, their argument is let's create a longitudinal patient record so that we have all the information at the point of care. Great. No one's going to argue with that. I think you and I would both agree that a truly complete longitudinal patient record would improve care. But here's where my path sort of diverges with where they're coming from. And I believe we should put the medical record in the hands of the patient, not the health system. If you really want to change healthcare, we have to free the data. And putting the patient at the center of the equation instead of the health system or pharma or payers or the EHR providers or even researchers is really going to do that. So when I throw that out, I typically get three kind of pushbacks. There's the argument against giving the patient data that Judy Faulkner was caught espousing, but she's not the only one. There's plenty of physicians who have said that, and they essentially say, you know what, the patients wouldn't know what to do with the data if we gave it to them. And there's just a certain level of arrogance that goes along with making that statement. I may say that to my 5-year-old. I don't have a 5-year-old, but I may say it to a 5-year-old, but never really to a grown adult. Another argument is that it will expose data to theft. And, that sort of has a level of hypocrisy to it, because in 2017, I'm just going to give you some stats real quick. So in 2017, healthcare had 477 breaches and 5.6 million records were lost. And that followed a 2016 that saw 450 breaches and 27.3 million records lost. And the article I actually pulled those from said, we're making progress because we went from 450 breaches in 2016 to 477, so we're slowing down the rate. 27.3 million records lost. It's crazy. I have a stack of identity protection offers on my desk from various health providers, and seriously, my credit card has never been stolen from Apple. We've seen models from really smart people who show that this is a viable option, like the Blue Button initiative from Todd Park. And I know I'm ranting here. I'll get to you in a second. And the argument that really puts me over the edge on this is, you just can't have it. And I know that HIPAA says that we can get our medical record, and in most cases, we'll get it in paper, or worse, we'll get it as unstructured data. And the reason that's worse is they don't even do us the courtesy of putting it on paper and paying for the ink and the toner. They make us do it because the next healthcare provider, we have to figure out a way to get it in whatever form they give it to us, to them. And and we've talked about this. It's not like we can't share discrete data elements. We've had the technology since the 90s, and the health systems either choose to not prioritize data sharing, or they don't have the appropriate skills, or they don't have the right incentives to get this done. What I'd rather see here, I know I'm ranting on what I don't like about it. What I'd rather see is sort of a change in our thinking of a patient-centric approach, which says, let's get the medical record in the hands of the consumer. So Epic and Cerner, suspend your fees for developers and implementers, and allow that data to flow out into devices that can actually be mobile with the consumer, because the consumer is the only constant at the point of care. I'd like to see us move from HL7 to APIs. I'd like to see a new model where we have maybe a whole person profile, our health record, our fitness, our food, our purchasing information, so that people, data scientists like yourself, can really do some things with it, but also that the consumer can benefit, right? So the consumer can say, I want to participate in this study, or quite frankly, they can sell the information. A lot of health systems do end up selling the information either directly or indirectly through third parties. That's a long rant, but and I know it's hard to follow a rant, so let's change this up a little bit. You're a data scientist, and talk to me about how the patient identifier would make your life easier as a data scientist, or what would you be able to do if the federal government mandated an identifier that perhaps you can't do today?
Well, a couple of things. First, I'm going to agree with what you just said, even though I hate to. And we didn't have any pre-discussions on this, but Apple's going to lead the way. We know they are. They're doing it right now. They've been working on it for quite some time. The data absolutely in the hands of the patient. We have technologies that allow for that. Blockchain being one of them. that'll let the patient decide, and in terms of potential emergencies and so forth. Is there a need for an identifier for data science? No, but I even think kind of stepping back, is there a need for regional health information exchange? There actually could be a national health information exchange that we could actually do in surrogate, apply EMPI to those patients based on a whole bunch of various characteristics that everybody on the line understands how that's done. Does it have to be mandated? No, it can be done. It can be done as a surrogate. So I think that I think one, you're right. Two, I'd like to see us get away from regional exchanges, and then regarding the data science and profiling and whatnot. So work that we're doing at the University of California Irvine with the Institute of Future Health is exactly what you described. We're building what we call personicles. So that basically is your profile, and it's unique, not because it's unique with a number attached to it, because it's unique in all its characteristics. That is you. And that doesn't, your profile is much different than anybody else's profile. It's a combination of physiology. It's a combination of, what labs have been attributed to you, your eating patterns, your exercise patterns. There's a whole bunch of ways that we can identify you as you without, imposing a national identifier to you. So from the data science aspect, yeah, absolutely. Sure, it would make it easier, but, data scientists are supposed to work around issues like that. And so that's kind of, how I would approach that.
That's interesting. It sort of flies in the face of that we're going distributed with blockchain over, everyone almost agrees, over the next 5 years, we'll go to distributed ledgers and records and whatnot. And this sort of flies in the face that says, hey, let's keep it centralized. Let's create an index that we can utilize and whatnot. No,
this is consumerism, right? Consumerism will continue to, eat into healthcare, I think, for the better. And, we'll have to do what the consumer wants.
Absolutely. All right. So let's kick to the second story here. And this is your story. So take it away.
Okay. This is on the topic of AI, and I think we'll be able to get a little bit controversial here.
So I'm going to bring that. Been on the last segment.
Well, let's even get even a little bit more. So this article is by Mike Millard, January 30th in Health Data, and AI is disrupting clinical practice. So how tech is implemented matters, and absolutely. And I'll kind of get into it, but I'll go with a story really quick. So back in the late 80s or early 90s at LA County USC, I'm also a trauma nurse and whatnot. We did a lot of predictive models and so forth. I worked with Dr. William Shoemaker, who started the Society of Critical Care Medicine. We actually built predictive models that for patients in trauma that would predict, depending on the therapy, what the outcome would be. We made a really big mistake back then. We called it prescriptive analytics. The clinicians went nuts. They didn't want a machine telling them what to do. And this is really what this article is all about. And this is almost, oh my gosh, this is almost 30 years later, right? So,
yeah.
Again, with AI, we can build out, beautiful models that I would like to say can assist. I like to call it intelligent assist, to be honest with you. I don't like the idea of using this technology to tell somebody what to do. I'd rather it produce a cognitive trigger. This is what is described in the article. If I can give you a heads up that something's going on that you may not have been aware of, that's fantastic. Then you can make a clinical decision and move forward. But so here's a couple of quotes. It has to do with skepticism, and that's what we encountered back then. Still plenty of physicians and clinicians have skepticism to spare, if not outright hostility. And a couple other ones is really, it's interesting. You really can't force these issues. If you come up with these great models and whatnot, you really can't cram it down anybody's throat. You can't say, surprise, here's what the diagnosis is. Somebody's going to slam their fist down and say, hey, forget you. I'm going to go back to what I've been doing for the last 30 years. So there's an adoption. So how do you get that adoption? And really, this article really points out that there needs to be an adoption. And the way you do it is you don't black box any of this stuff. Many folks out there have, their models, their proprietary models, and this, that, and the other thing. You've got to show how you got to, where you got, what data elements you used, what weights you attributed to them, what was a neural network that was employed, was it random forest? What did you go through all the way through the process to get to the point that you're at now? And how accurate is it? Do you have an ROC curve to show? The various matrices and so forth. What's the precision? What's the recall? You have to be able to demonstrate that, and you have to be able to demonstrate it with their data. And you really can't make statements like, this model will work everywhere, because they won't. They're very geo-specific. What works in Southern California isn't going to work as well in Sarasota, Florida. It's going to need some tweaking because of the demographic nature and even some of the external factors. So I think, Mike put a really nice, package together, saying, yes, AI is important, but we need to kind of go through it in an adoptive, kind of way, and not just, kind of throw it out there. And, where does it fit in best? Don't try to make a problem and then solve it. Try to solve problems that are, already out there.
Absolutely. And this is now the job of the leader, either the informatics leader or the data science leader or chief information officer. It's cultural change. And it's really interesting because, you sort of mentioned, so this really, it's an article from Healthcare IT News. So it is a plug for the machine learning and AI sessions at HIMSS in Vegas in a couple of weeks, March 5th. The project manager, they quote a bunch in this, is Jeff Axt. He's project manager and system analyst in the IT department of the Hospital for Special Care in New Britain, Connecticut. And he does say, if you go into a department and say, surprise, this is the diagnosis from a machine, you're just going to, it is a visceral reaction. But I think that's also why someone like yourself has been successful. You have that clinical background and being in the ER and really understanding how these things play out and how technology is adopted. We almost need more clinicians to get into this space so that they can help people to make those transitions of saying, hey, I understand that the AI model isn't perfect, but neither is a human. A human isn't perfect either, right? And so if the two can figure out how to help each other, and as you say, those cognitive the triggers that help both become better, that the clinicians are training the AI to be better, and the AI is helping the clinician who's busy running from patient to patient to see something that maybe they didn't see, and that transition is going to be interesting. So anything else you want to say about this article? We're going to jump right back into AI in the next segment, but anything else you want to say about this article?
No, that's fine, and we'll continue. And I'd like to kind of bring in my students' take on it as well in the next segment.
Oh, that'll be interesting. All right, so second segment, we typically talk about leadership or tech talk, and clearly we're going to jump into AI. And give us a couple more use cases around AI in healthcare. What do you see? Well, actually, let me step back. Are you doing work outside of the U.S. with AI at this point?
Yeah, so we're working in the UK with it's in the mental health arena. So in the UK, the number one cause of death for males under 50 is suicide, and we're taking a little bit different approach. And the concept is to identify those at risk, but we're never going to be able to. And I don't believe we'll be able to actually determine where lightning is going to strike. We're going to take we'll let you know where the thunderstorms are, and then those that might be affected by those thunderstorms, and you can take the necessary action. So the idea is to really understand some of the factors that are involved in somebody making a choice like that. So this is where big data and the data science comes into play, because we got to bring in, social media for that. We got to bring in the temperature patterns. We got to bring in past, suicide patterns. We've got to, with consent, bring in the various patients, social feeds and whatnot. So you think about bringing all that in, and then letting the folks that are following, those patients, giving them a heads up, saying, hey, these are the folks that are, susceptible at any particular point in time. And that really changes, as the days go by. So enough information so that, they can, reach out and, make sure folks are okay and whatnot. That is a little bit different approach.
That's fascinating, and actually pretty relevant given the Florida school shooting. That I actually wrote this down. That lightning and thunderstorms. We're probably not going to be able to predict that this student at this time is going to go into this school and do this action, but the whole idea of thunderstorm, there's enough activity going on that you might want to take shelter, or you might want to look into something. So data science isn't at the point of saying, it's this person at this time, but it is at the point of saying, hey, there's a storm forming over here. We might want to get in front of that. Is there a difference in the UK versus the US in terms of adoption? I mean, are they more prone in the UK, or are we more prone in the US to be adopting AI type models?
I think it's pretty much the same. It meets with the initial skepticism, which is important because it keeps us on our toes. So it's not tell me, show me, prove it to me.
So real quick, give me 3 AI healthcare models in healthcare that you've seen that are effective. So you gave us a mental health. Give us a couple more real quick.
Sure. I think we did mental health. The patient deterioration that I talked about earlier, patients that are likely to crash, patients that are likely to enter a sepsis pathway, so treatment can be begun earlier. Outside of that, when you're looking at deep learning, machine learning, finding those patients that are likely to be, and we're doing this for a state in particular, that are likely to be have an opioid problem. So if you think about all the different data points that you can bring in and do those triangulations and whatnot, identifying. I think even from a data science, not necessarily an AI, but a data science, finding those patients within our populations that are pre-diabetic or that are hypertensive yet undiagnosed. One of the other UK projects is identifying patients that have AFib, that are not being treated, they're at risk for stroke. So there's a lot we can do with the data that we have, initially. And I think that's how data science makes its initial wins.
So I mean, so you have Watson, and we've seen some some crash and burn type scenarios with Watson. Specifically, MD Anderson was a crash and burn kind of thing. And when we talked about it, when I've talked about it with others, they said, it was the quality of the data. We couldn't get the data to the point of actually being able to do the things we wanted to do. Is that because there is a data quality problem, or is that because we're not choosing the right use cases?
Sure. So IBM does some wonderful things in AI. Watson in particular was a system developed to answer questions.
Yeah, like Jeopardy.
I'll keep it that I'll keep it as simple as that. So you can ask a question if the answer is within the confines of Watson. If it's not there, then there's no response. There's a lot more. Again, this is where I really think that it's really important that we think about how these technologies can assist us. Assisted intelligence.
So what's give us an idea of some of the good data sources that you're utilizing. I assume bedside data is pretty consistent, right? It's sending you the I mean, that data is very consistent, and you're consuming probably as much of that bedside data as you possibly can. Are there other sources of high quality data that you're utilizing?
Yeah, sure. So anything off of physiological monitor, ventilator, smart pumps. So you think of anesthesia machines. They all are accurate, pretty accurate, and so they are accurate, like you stated. Every now and then you'll get a weird signal. Somebody will turn a stopcock, and you'll get a CVP of 13 that jumps up to 310, or an arterial line is occluded, and that jumps up. Those can be taken care of within a system. Laboratory data coming in, pathology, all of the various source systems, very clean. Especially if it's been ontologically right sized, but we can make we can fix that. But it really is, what data do you need to do whatever it is you're going to do with it. If you try to chase 100%, you're going to be in trouble. And within the realm of data science, we can help out if things aren't totally perfect. There's things that we can do. There's methods to account for missing data or data that's outlier or out of range or not expected.
Yeah, and at the risk of going a little bit over on this episode, how does a health system get started with their AI?
Sure. So a commitment to do the education process, to really understand what it is you want to do before you jump into it. I see healthcare organizations that hire data science teams that really don't know what a data scientist is. And I'm going to give you my definition. I say I participate in data science. I do not call myself a data scientist, and I'll tell you why. The rigor of a PhD program prepares you for the rigor that's required for data science. It's absolutely essential because you can get sloppy, you can get lazy, you can jump off the the wrong track, and you can really lead an organization down the wrong path. Folks like myself are very assistive to data scientists. Data scientists on my team are PhD folks. I work with them. We get to where we need to go. So I think that before you go out there and hire the team, make sure it is you understand what you're hiring, what you want them for, and then maybe bring in some folks to help you, put that team together. Because if you don't know what data science is really all about, or what a data scientist is, you could be 6 months down the road and you go, uh-oh, and now you've lost 6 months. So that's kind of spend as much time as you can on education.
Yeah, and I would say I made some mistakes there. I brought in some data scientists, and they were immediately gobbled up in the and pushed back down into the day-to-day
analysts.
And
yeah,
it was an awful waste. It took me about 6 months to extract them out of some of those projects and get them to focus on a little higher level things. So.
And Bill, from an interview perspective, just one little tidbit: if you're interviewing a data scientist and you don't understand what the heck they're saying, then you probably are interviewing a data scientist.
Yeah, that's probably true. The distinction I found was they don't answer questions; they tell you which questions you should be asking. And
that's correct.
They look at the data, and the data informs them, and it's amazing the number of tools they have, good ones have in their bag. So it's time to close the show. Favorite social media post of the week. I'll start it off. This is from William Walders, and it's just it's a comic strip. And it has a gentleman sitting across from a receptionist, and the receptionist saying to him, "You cannot list your iPhone as your primary care physician." So, Charles, to you, what's your favorite social media post?
Sure. My social media post today comes from a colleague of mine, Brian Norris, colleague we've worked together for years. His Twitter handle is geek_nurse, and he put out this week, "Fellow nurses, we need to elevate our seat at the machine learning AI tables, bring that clinical and digital acumen to bear. I think we need a nursing coalition of nursing data scientist folks driving the digital aid forward," with a shout out to myself and Judy Murphy at IBM.
Awesome. So I assume you're going to be at HIMSS? You're going to be at HIMSS?
Oh, I'll definitely be there, as well as all of my students will be there. And the last kind of shouting part, they cited mostly millennials, they cited on the side of AI, the systems telling people what to do versus the systems assisting people. So I just wanted to get that out to them. Yeah.
I trust the machine more than I trust the person.
Well,
we could do that. I would love to, I'm going to be at HIMSS as well, and I would love to catch up with you and your students. That would be a lot of fun. So That's all for now. You can follow Charles at N2 Informatics RN on Twitter and me at the Patient CIO. And don't forget to follow the show on Twitter as well, This Week in HIT. And check out our new website. And Charles, where are you calling? You're calling in from Jacksonville?
Yeah, I'm calling from Jacksonville, Florida, Clearsense at clearsense.com.
All right. So I will. One of the things we do on the website, you'll notice, is the image is usually a skyline of where the guest is calling in from. So we will have a skyline of Jacksonville. Jacksonville has a skyline, I assume.
Yeah, pick Jack's Beach.
or maybe just a beach shot. That's probably a good way to go.
Yeah.
Well, hey, if you like the show, please take a few seconds, give us a review on iTunes and Google Play. That's all for now. Please come back every Friday where we will do this again with another great thought leader. Next week, Dr. David Benzema is going to be here. 2 weeks, David Baker, CIO for Pacific Dental. I think that'll be an interesting conversation because that's also the week of him. And so that's all for now. Thanks for joining us.